Recent advancements in health informatics has helped in the fight against childhood obesity in the United States. Childhood obesity affects adolescents and children in the United States at alarming rates. It was found in 2015 that 32% of children and adolescents are overweight or obese. Childhood obesity can increase the risk for many multiple chronic conditions that can continue into adulthood, cardiovascular problems, diabetes, stroke, and orthopedic problems. Childhood obesity disproportionately affects children coming from families with low socioeconomic status and income. That's equally difficult because when children are obese, those families have difficulty affording treatments for their obesity as well. The National Committee for Quality Assurance recommends that physicians monitor BMI and provide nutrition and physical activity counseling to children that they treat. It has been found that physicians often feel the conversation regarding children's weight is a difficult conversation to have with their patients and their families. Childhood obesity can be a safety and quality issue for many reasons. As mentioned, providers often find it difficult to counsel patients regarding their weight. This can be for multiple reasons. Parents are often sensitive to discussions about their children's weight, either due to their own weight and eating habits, or just because they have a difficult time recognizing that their children are either at risk or already overweight or obese. Physicians also have a weight bias that is learned during training, which makes it difficult for them to address overweight and obesity in their patients. Physicians also have difficulty working with interdisciplinary teams, including dietitians, social workers, that would be helpful in the fight against childhood obesity. Obesity can cause multiple chronic health problems. This is a safety and quality issue for our healthcare system in general. As our population ages, our healthcare system is reaching some of its maximum levels at hospitals, and a lot of these patients are in the hospital for treatment of chronic issues like the ones listed here: asthma, orthopedic injuries, liver disease, GERD. All of these can be caused by obesity. Additionally, children who are overweight or obese can have self-esteem issues and can have difficult social interactions with their peers who may bully them or tease them due to their weight. As previously mentioned, obesity disproportionately affects children of low socioeconomic status. Prevention is really important in this community. Almost all children, even if their family is low income, does see a primary care physician. And so it would be great if these physicians can prevent childhood obesity before it happens. Because children that are obese, their families may have difficulty affording treatment options like dietitians, nutrition programs, and counseling. Health informatics and childhood obesity. Clinical decision support systems are parts of the electronic health record that can be utilized to alert providers of certain irregular lab results or patient data, or prompt physicians to order treatment plans or medications when patients have certain ailments that are recognized in the electronic health system. Clinical decision support systems can be utilized specifically in the case of childhood obesity by alerting physicians of when children have high BMIs or borderline BMIs and are approaching overweightness or obesity, so that providers can begin discussing counseling or support services with these families. Research has shown that physicians are more likely to initiate these interventions if prompted with CDS systems. In one study, the diagnosis of childhood obesity increased from 40 to 57% with the use of these kinds of alerts. It was also shown that children were more likely to be scheduled for close follow-ups with the use of these CDC alerts, CDS alerts, meaning that physicians are following them more closely. This is an example of a CDS alert that can be that may come up if a patient's BMI is high. You can see here that it says the patient's BMI percentile is over 85%. BMIs from 85% to 94% indicate that a patient is overweight. Above 95% means that the patient is obese. So in this case, it's showing that this pediatric patient is overweight, and it's suggesting some labs and some documentation that the provider can use to show that they've started to treat this patient's obesity. Another health informatics tool in the fight against childhood obesity has to do with prevention. It's widely recognized that prevention is the best way to end childhood obesity, as treatment is very difficult. One study showed that machine learning techniques can be used to analyze patient data from age 0 to 24 months to identify predictors that show up before the age of 2 that can lead to childhood obesity. One indicator of the risk of childhood obesity was rapid weight gain between 12 to 24 months. This was a bigger indicator than any other time frame of a patient being overweight before the age of 2. It's worse if they go from not being overweight to overweight in a rapid time period. The CDS systems can alert physicians of these early warning signs so they can begin early counseling regarding healthy weight gain and obesity prevention with these families. One CDS system, a Child Health Improvement Through Computer Automation, used this data to develop a questionnaire that is suggested to be used at the 24-month visit to screen for obesity risk. This is a copy of the questionnaire. It is difficult to read, but it does include questions that screen for smoking in the home, parents' anxiety level, developmental milestones, and some more indicators that, if present, mean the child is more at risk for obesity. Again, it's recommended that this be used at the 24-month visit, and that way providers can start early interventions if it seems that the patient is at risk for childhood obesity. Another important way that health informatics can help with the fight against childhood obesity is the sharing of successful programs. For over 20 years, experts at Stanford's Children's Health have been working on a weight management program that has been very successful in helping families and children reach and maintain healthy weights. The Centers for Disease Control and Prevention, or CDC, recently recognized that the program would be helpful across the nation and are providing funding for the Stanford Children's Health Hospital to package the program so it can be offered across the country to providers and can be used with different families. Specifically, the CDC is hoping that this will help the weight management program reach low-income families that otherwise would not have access to Stanford's program. IT experts are being used to ensure this program is available and accessible for providers across the country. The program will include videos, animation, assessment tools, monitoring, and feedback that can be used across the country. With any advancements, there can be pros and cons. Some pros to health informatics in childhood obesity. is that the CDS alerts can remind providers to screen and treat patients for childhood obesity, hopefully catching it early and helping patients reach a healthy weight. Advancement in health technology innovation can also make successful pediatric weight management programs available nationwide, like the example of the Stanford program being adapted to be shared digitally with providers across the country. Some cons with health informatics being used for the control of childhood obesity is some studies have shown that 33 to 90% of clinical alerts are ignored by providers. With advancements in CDS alerts, some providers now suffer from what is known as alert fatigue and just click through pop-up boxes or alerts that come up when they're trying to document on a patient. This could mean that a provider can miss an alert for childhood obesity and not correctly diagnose or treat for that patient. Some providers feel it's better that they should just have to review all data and make decisions on their own instead of using CDS alert systems. Additionally, programs that work in some communities may not be applicable nationwide. The fact that the pediatric weight management program has been successful in Stanford does not guarantee that it can be applied to communities across the country. Community buy-in and partnership with community organizations is very important for effective weight management programs. It does not just come from the primary care provider. Community organizations need to promote physical activity, access to nutritious food, and further interventions to make sure that childhood obesity is adequately addressed. Healthcare policy and technology. The U.S. Department of Agriculture is now using technology to promote their MyPlate program, which shows people across the U.S. how to have healthy eating habits. MyPlate is now available in an app that can encourage people to eat balanced diets. You can track your own eating throughout the day and set goals to improve your healthy eating habits with use of your smartphone. This is a very good way to make free nutrition counseling available to people that otherwise may not be able to afford to access nutrition services. Another initiative in healthcare policy and technology is that the CDC has developed a childhood obesity data initiative known as CODI. They're hoping that patient data across different electronic health record systems can be integrated so there is a simplistic and cohesive report of a child's weight and health data throughout their lives in order for the CDC to be able to identify community level risk factors and interventions that were successful and not successful across the country. The American Medical Informatics Association discussed the CDC's CODI program at their 2020 summit. Healthcare professionals can access information about CODI through this organization. This is very important because it's been found that primary care providers have the most responsibility in educating patients to help prevent childhood obesity. A research study could be designed to look at success of CDS alert systems in the diagnosis and treatment of childhood obesity. It would be best if this was a quasi-experimental retrospective study because it wouldn't be fair to have a control group that didn't receive an intervention. So it would be best if a researcher identified 2 already existing groups that were similar in other ways in geographic area and with similar socioeconomic status. The control group would be patients that see a provider that does not yet use CDS alerts for diagnosis and treatment of obesity. and the comparison group would be